ICG forms a very important cause of significant exudative maculopathy. You know, almost 1 in 2 of our patients, if we do an ICG or if we look for a non-ICG based diagnosis, you know, we'll see that those NAMD patients actually turn out to be PCVs. So the previous set of Indian guidelines for the management of PCV were published way back in 2018, and they were done with a literature search only up to 2015. So, and since then many new things have evolved in the management of PCV, especially over the last 3 years. This complete absence of PDT, you know, that is considered to be the gold standard. Hence, for these reasons, the VRSI convened the Indian PCV panel to conduct a systematic literature review and provide updated consensus recommendations for the diagnosis, treatment and follow-up schedule for PCV patients. So, as a beginner, the nomenclature of polyp has been updated to polypoidal lesions, and branching vascular network has been updated to branching neovascular network. And this is just to better characterize the neovascular nature of the disease process in these eyes. Then we come to the main gold standard that was considered till now, that is ICG. So according to the previous guidelines, it was the gold standard for diagnosis of patients with PCV, means it was mandatory for all these patients. However, according to the newer recommendations, it is mandatory only for clinical trials, but it may actually not be needed in our real world, because our primary line of management has been switched to anti-VEGF monotherapy. So we don't actually need to recognize those polyps, whether they are present in the subfoveal or juxtafoveal locations. Or we don't need to measure the GLD because the PDT is completely out of the picture. In real world, ICG may be needed only in patients, you know, who are very poor responsive to anti-VEGF treatment, where we need to locate extrafoveal polyps that can be treated by thermal laser therapy. Similarly, even FFA is no longer recommended for the management of these patients unless we are suspecting maybe an underlying CSR where the source of the fluid is CSR itself and not the presence of polypoidal lesions in these patients. So then we come to the characteristic, the main non-ICG based diagnosis, that is OCT. So the two features that are very important include presence of the thumb-like or the sharp peak PED that can be seen, and the tomographic notch. So both of these, they signify the presence of these polypoidal lesions in the sub-RP space. The next very important OCT biomarker includes the presence of the hyporeflective lumen surrounded by a hyperreflective ring that is attached to the undersurface of the retinal pigment epithelium, and the presence of the flat irregular PED or the double layer sign that actually represents the branching neovascular network. So these were based on the 2018 guidelines. So now newer features have been defined, as well as the older features have been defined better. Like the sharp peak PED has been defined as a PED having a vertical elevation of more than 70 degrees and a height to base ratio of more than 1, and the tomographic notch has been relabeled as a complex or a multilobar pigment epithelial detachment. The other features includes the presence of a thickened choroid that is age matched or matched to the axial length of the patients, a subfoveal choroidal thickness of more than 300 microns, and presence of a focal dilated Haller's vessels which is present along with the compression of the choriocapillaries. That is very important, because when we see many of these patients may just have a dilated Haller vessel, but the choriocapillaries may be absolutely fine, so they may not be classified as patients having a diseased pachychoroid. Next includes looking at the on-fast OCT image of these patients and looking for these complex RPE elevations that are represented by the black in color, and there is hyperreflective BNN that can be recognized in the central part of the lower image. So that is a network that connects the multiple PEDs. And last is the fluid that is present in PCV is usually mostly subretinal rather than an intraretinal fluid. So in order to differentiate between NAMD and PCV based on OCT, there are major and minor criteria have been proposed. The major criteria include presence of a sub-RP ring-like lesion, on-fast complex RP elevation, and presence of the sharp peak PED. And the minor criteria include presence of the double layers of sign, presence of a thickened choroid with a dilated Haller's vessels, and presence of the complex or multilobar PED. So then coming to the role of OCT angio, so it does provide some amount of complementary information, especially for recognizing the network. So many studies have shown that it is more sensitive than actually ICGA in recognizing these neovascular networks. But their widespread application of OCT angio is not recommended at present, because the actual detection rate of the polypoidal lesion is quite low because of the low flow, and there is a lot of scanning errors that can happen in these patients. because of presence of artifacts and auto-segmentation errors. So then we come to the treatment of PCV. So if the patient is having an inactive PCV, it is better to observe. If the patient is having an active asymptomatic PCV, like the presence of a small polyp in a peripheral location or in a laser location with a 6/6 vision, we can observe those patients. And if there's an active symptomatic PCV, it has to be treated. Then it depends on the location where the polypoidal lesions are present. So based on the previous guidelines, any active subfoveal or a juxtafoveal PCV had to be treated with a full-fluence PDT in combination with anti-VEGF injection. However, that is no longer recommended, and anti-VEGF monotherapy remains a definitive choice for the management of these patients. This is not just because of the unavailability of the PDT, but because PDT itself is associated with many drawbacks that includes complications such as hemorrhages, RPE rips, and since these lesions are known for recurrence, recurrent episodes of polypoidal lesion that are treated with PDTs can worsen the choroidal ischemia as well as atrophy. And additionally, PDT may be difficult in polyps that are located in peripapillary location as well as multifocal lesions. So then coming to the choice of anti-VEGF agents. So according to the previous guidelines, ranibizumab was considered to be the preferred anti-VEGF agent based on the level of evidence. And at that time, the results of the PLANET study were not out. So at that time, aflibercept was considered only in patients who were refractory. However, if we, based on the updated literature, aflibercept remains the preferred anti-VEGF agent for the management of these eyes. This is because it has got a higher activity against VEGF and an additional activity against PGF also. And with a longer half-life, we can do a treat and extend regimen and maybe increase the patient to even Q12 or a Q16 regimen in these eyes. Brolucizumab can be considered in these patients only who are refractory to aflibercept or ranibizumab because there is very limited evidence for that, as well as because of the higher risk of intraocular inflammation that has been documented in the literature. Now, if you just look at the evidence, you know, the 24-month AVIS study had shown that monotherapy with ranibizumab was inferior, whether in terms of visual acuity or a polyp regression rate or with the median number of injections. Whereas in the PLANET study, it showed that aflibercept was non-inferior to the rescue therapy. So if we look, although the direct comparison between these two studies is difficult, but the AVIS study proposes ranibizumab to be given in combination with PDT, whereas PLANET study indicates aflibercept monotherapy may be sufficient enough. Now we just a minute more, sir. So if we look at there is just couple of studies that have evaluated brolucizumab in PCV, and that includes one subarm of the HAWK study. And although it showed very good outcomes, so the rate of intraocular inflammation was 50.4, and another study by Ogura had showed an inflammation rate of 19% in these PCVI. So there is very limited evidence, and the rate of inflammation is very high in these patients. And for follow-up of these patients, it can be done on serial OCT, and treating this patient with treat and extend regimen is better because it has got a better chances of visual acuity improvement as compared to the PRN regimen. And multiple literature have shown that patients who are refractory to either ranibizumab, bevacizumab, or even PDT have shown very good response to aflibercept, be it in terms of polyp regression or visual acuity improvement or the need for the injections. So just to summarize, the updated guidelines are based on the evidence from the literature, and they emphasize that PCV is a multifaceted disorder that needs an individualized therapeutic strategy. So timely imaging with OCT is very critical for these patients, and a tailored treatment with anti-VEGF monotherapy, especially with longer acting agent like aflibercept, should be planned. And the current recommendations would provide a broader framework for the treating physician for the diagnosis and management of PCV for optimal outcomes. So these guidelines are freely available in the August edition of the Indian Journal of Ophthalmology in case it may interest you. Thank you.
Yeah, thank you, Jay, for this, again, a very illuminating talk. You see, believe me, everybody learns, but a couple of days back only I had one proven patient of PCV diagnosed by some doctor,
Okay.
put on biosimilar of ranibizumab.
Okay.
And obviously she was, 3 doses not responding, but aflibercept, what you rightly said, treated her nicely.
Okay.
So that's one take home. It's a underdiagnosed entity for the sake of, but one thing you have made very clear, that ICGA may not be required for definite diagnosis, because all of us lived under this impression that ICGA is a must, but because of this lot of work being done by your group as well as by Giri and all, they show that OCT, this can in majority of these patients. But one thing you see, I for one hadn't had any bad experience with PDT. What you said, PDT is crossed, but low fluence PDT actually for me did wonders during that. Full fluence PDT, I agree, maybe have some choroidal hypo, this thing, permeability, but low fluence PDT does not.
Yes, sir, because low fluence PDT works well, especially for polyps, but the networks are usually very resistant. So if we see those
So if you have a combo of low fluence PDT plus aflibercept,
yeah.
that to me may be the most, but since we don't have it, so we have to depend only on monotherapy. Chal, thanks a lot.
Thank you.
Any Srinivas or Madam, any?
I have faced
Which are the biomarkers which are not being considered now? Because there were so many biomarkers like hyperreflective foci, 0 to 10, 10 to 21, more than 21, and majority of the authors are now telling that it is outdated and we don't do it. And the subretinal fluid over the scar was considered once a day not to treat it. Now with the OCTA, the perilesional halos, the loop anastomosis. So which are just 1, 2, 3, 4, which are not being considered now as a biomarker?
I think one of the few things is, the sub-RP biomarkers are the one, that are increasingly being recognized. So, I would give that benefit because that has come into picture because of the advent of brolucizumab. Because prior to the advent of brolucizumab, sub-RP level or a sub-RP fluid was never considered in our treatment plan or treatment management. So the resolution of the sub-RP fluid, that is actually meaning resolution of the PD is very important. A lot of work has been done on CVI, the choroidal vascularity index, how the choroidal remodeling is happening. And another thing is a surgical thing is the next that can be considered for these patients because based on one of the recent papers by Flood et al, they have shown that dilated vortex vein has to be the primary pathogenesis in the entire pachychoroid spectrum, and they have showed asymmetric vortex vein dilatation. So they are saying maybe a scleral window could be the next thing that may come up within the next 3 to 5 years that may help to halt the disease at an early stage, the entire spectrum at an early stage.
Yes.
I think we should move ahead. We have 3 more presentations.
Thank you.
No,
Thank you.
till the time we call upon Vishal.
But Jay has presented very nicely, and what is the conclusion is that today's anti-VEGF world is that there are only, there is not any single condition where aflibercept is not recommended or is the drug of choice. Only questions comes of the cost. Now both the presidents, past president and present presidents are here. Can we make some effort that Zaltrap can be brought into the market like an Avastin, so that there is no need of using any other molecule at all in our practice, either Eylea or Zaltrap, that's all. And you don't think of anything else.
It's again a big debate, sir.
This, we will not open up this Pandora box, and neither we are agents for Bayer Group.
I would like
I
to.
agree.